Welcome to Health Professional Radio. I'm your host, Neil Howard. In this segment, we're going to have a conversation with Dr. Elliot Hirsch. Now, October is Breast Cancer Awareness Month, and Dr. Hirsch, a board-certified plastic surgeon and chief of plastic surgery at Providence, Cedars-Sinai, Tarzana Medical Center, is joining us on the program to talk about whether a breast cancer diagnosis will always require surgery or if there are some other options. Thanks for joining us on the program, Dr. Hirsch.
Thank you.
Now, of course, I mentioned that you are a board-certified plastic surgeon. Is that why you went into medicine?
Yeah, it's plastic surgery. It's a different kind of specialty. It's we like to say it's a transformative specialty where you're not always curing people, but you're helping them and you're making them feel better, and not just doing medical, but a lot of it is just making them feel better about themselves too. So it's not your routine medical specialty. It's a little more to it.
With breast cancer being so prevalent, surely you see all different types of surgeries, reconstruction, all types of things. You're dealing with all types of different people. When you're diagnosed with breast cancer, does that mean that you're going to have surgery?
Well, everybody is a little bit different. In general, most of the time, when patients are diagnosed with breast cancer, the first person they see is a surgical oncologist or a breast surgeon or even a medical oncologist. And that person is a specialist in the treatment of breast cancer, and they will talk to them about what are their oncologic options. Most of the time, the oncologic options include a different one of two types of surgery. Usually there's a lumpectomy, which is a removal of the tumor, and that's followed by radiation treatment. The other option is to do a mastectomy, which is a removal of the breast. That may or may not be followed by radiation treatment. Based on the characteristics of the tumor itself, sometimes they'll do chemotherapy, and there's lots of different types of chemotherapy and hormonal therapy, and sometimes maintenance hormonal therapy. They may even do that before surgery. Then there's the reconstructive options. It just depends on what the breast cancer surgeon decides is the best way to treat the tumor. There's a variety of things that we do, including tissue reconstruction using the patient's own body, implant-based reconstruction where we use something called a tissue expander or an implant.
So basically, surgery is going to be involved in some shape, form, or fashion, right?
In most cases, yes.
How do you determine which is the right course of action?
It's a little bit different for every person. Oftentimes, it comes down to whether or not a patient can psychologically accept the risk of breast cancer recurrence. So, for example, in a mastectomy, when patients undergo this for their oncologic treatment, they have a not zero chance of recurrence of the breast cancer. It's still around 2%. So even though all the breast tissue is gone, there's still a chance you can come back. However, once you've had a mastectomy, you don't need mammograms anymore, and it's a different type of screening afterwards for the recurrence. It's just exams. If you do a lumpectomy, there's a 7 to 9% chance that the tumor is going to come back. So it's a slightly higher, but the long-term survival rate is still the same between the lumpectomy and the mastectomy patients. However, lumpectomy patients still need to have mammograms, and that psychologically is very tough for patients to accept that they still need to have mammograms, they can still have biopsies, they still have a slightly higher chance of recurrence, even though the survival is the same. Also, with a lumpectomy, the patients have their own breast tissue. They don't need reconstruction in most cases.
It seems that there's a very long process from diagnoses to reconstruction. Is there a way that you can begin reconstruction while healing is taking place, or is that something that has to happen once all healing has taken place?
Most of the times now, we do reconstruction at the same time as the mastectomy. So usually the sequence of events is patient is diagnosed with cancer, then they'll see their breast oncologic surgeon, they'll see a plastic and reconstructive surgeon, and they'll see a medical oncologic surgeon. If the breast oncologic surgeon and medical oncologist decide that there's no chemotherapy necessary before surgery, then the first line of treatment is surgery. And if it's a mastectomy, very commonly there's a plastic surgeon in the room at the same time as mastectomy to perform what we call immediate reconstruction, which means reconstruction at the same time as the mastectomy.
What is that healing process like? I mean, you talked about psychologically accepting possibility of recurrence. We have part of the body that's going to be changed drastically. How is that process? What type of toll is it going to take as this process goes on?
It's the toughest part is in the first few weeks after a reconstruction. Patients they're pretty sore, and most of that is from the mastectomy, but the reconstruction certainly adds a little bit more recovery time. They have surgical drains, which help reduce the amount of fluid in the breast after surgery. They often are taking antibiotics, pain medication, and that's a lot. And then every time they look in the mirror, they don't see a finished reconstruction. It's a process. And as the patient heals and we begin if we're using a tissue expander, if we begin the expansion process, they look better and better. But it can take 4 to 6 weeks until they're at full strength again, and it can take 3 months to get to what's usually the second stage of surgery, where we take out an expander, put in a permanent implant. So it's a long process. There's ups and downs in the process, but as long as patients keep their eyes on the goal at the end of the road, most of the time they do pretty well with it.
Breast cancer isn't only something that affects women, it affects men as well. Do you see the reconstruction request in men at all?
No, and there's different reasons for it. In a male, typically there is less breast tissue. So a male chest is supposed to be flatter, and when a mastectomy is performed on a male, usually the biggest difference is that they don't have a nipple and areola. So it's not like we're trying to recreate the shape of a breast. They're just trying to give a nipple and areola. And in our office, probably the best way to do that is with a tattoo.
October being Breast Cancer Awareness Month, are you aware at what age women should, start getting mammograms?
At 40, unless they have a strong family history of breast cancer. That's what the American Society of Breast Surgeons and the American Cancer Society recommend.
And what are the recommendations, for men? I mean, the colonoscopy seems to be the number one priority on our list. But when it comes to the possibility of getting breast cancer, how are men screened? Obviously, mammograms aren't an option, but is there any type of blood screening or anything? No,
if there's a strong family history of breast cancer, and for example, like if there's the BRCA gene, if the man carries the BRCA gene, he does have a fairly high chance of having a lifetime risk of breast cancer. So he would see a breast cancer specialist and follow with them, maybe every 6 months, maybe every year, but just consistent follow-up with a doctor and self-exams. And if anything changes, then obviously he could be seen promptly and treated accordingly.
As it relates to breast cancer, what is a dangerous diagnosis? Explain that to our listeners and talk about ways that we can prevent a dangerous diagnosis. Well,
cancer in and of itself is it certainly has the potential to be a life-threatening diagnosis. These days, most of what you'd say more of the dangerous diagnoses are based on the biomarkers or the genetic characteristics of the tumor. And unfortunately, that's not something that you can control. It's determined by the tumor biology. There are some tumors that behave very aggressively, and there are other tumors that are very treatable. But unfortunately, it's not something that could be controlled. The most important thing for breast cancer is to catch it early and don't wait on it once it's diagnosed. So like we said before, getting those annual mammograms after women turn 40, unless they have a strong family history of breast cancer, that's the best way to do this is to be proactive with your health.
We'd like to get some more information about your practice and about Breast Cancer Awareness Month and breast cancer in general. Give us a website where we can get some more information about what you're doing there at Cedars-Sinai.
Sure. My office website is www.hirschplasticsurgery, HIRSCH plasticsurgery.com. We also have a Instagram handle, Hirsch Plastic Surgery, and a Facebook page, which is also Hirsch Plastic Surgery.
Great. Dr. Hirsch, thank you so much for joining us here on the program this morning.
Thanks for having me.
You've been listening to Health Professional Radio. I'm your host, Neil Howard. Audio of this program is available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes. Listen in, download it, SoundCloud, and be sure and subscribe to our YouTube channel at youtube.com, Health Professional Radio.